To everyone, thank you very much for the opportunity to talk this afternoon. It's wonderful to be here and to see some familiar faces and also a lot of new faces. The disclosures I share are the grant funding, which I'm very fortunate to have. We'll come back to that. So I'm a pulmonary physician. You're hearing from people with different specialties and areas, and so I take care of both children and adults with interstitial lung diseases and rare lung diseases. And I just wanted to start with this because there are a lot of different rare diseases. Our government, based on those definitions in the United States, there's more than 7,000 rare diseases. These disproportionately affect children. Around the children's hospitals where you go, they're filled with children who have rare diseases. The problem is they're just all different rare diseases. And part of what I think the strength of this foundation is the way that we're pulling together many different disorders. And so sometimes when we talk about research or specific topics, some are emphasized. It might seem more than others. But I just wanted to take a moment to say, my clinic is full of kids who maybe are undiagnosed or have different types of rare diseases, and they're all very important to us. We move forward in sometimes faster than others based on the numbers that we have or patterns that we're able to see. But our goal in what we do is to try to do research to understand what causes these disorders and how to treat them. So because no one seemed to want to get up and stretch, I'm going to ask everyone to stand up who has sat with their doctors and feels that they don't know enough to take care of their kids. So the only reason to be seated, other than a medical indication, is if you feel that that everything that needs to be known is known. So, no comment in the back. But I say this, partly to make people stretch, but also because this is, I sit on the other side of it. And it's uncomfortable for me and for all of us, and that's why the physicians are here. That's why this medical group is formed, because we recognize that we don't know everything we need to know to treat your kids, and this is part of the structure and the network that we hope allows us to move forward faster together for those answers. So I think this has already been introduced a little bit by some speakers, but I wanted to kind of give my version of how all these different disorders wound up being grouped together, if you will. So childhood interstitial lung disease, as you've heard, is not one diagnosis. Used to be, maybe 15 years ago, that you got a diagnosis of ILD and that was it, but now we tell the physicians that's just a starting point to keep going. And it's a term that comes from the idea that there are a lot of disorders that have different causes, but they affect the same part of the lung. So I'm showing here the lung with the schematic that where we're going to get to in the interstitium, the interstitial part of interstitial lung disease, is all the way out in these yellow air sacs called the alveoli. So you come down the tree trunk, all the way out the branches, all the way to the little twig airways and the air sacs that sit on the end of them. And so when we look at lung tissue, what I'm showing you here is the red arrow is pointing to a small airway. That's one of the tiniest twig branches that's called a bronchiole. There's a blood vessel next to it. And then pretty much everything else here are alveoli. So those yellow sacs, when we cut them in cross-section and put them on a slide and put chemical stains on them, then we're able to see the alveoli. And so most of lung biopsies should be white because that's air. Okay, and when there are too many cells or too many scars, that kind of thing there, then they start to become less white and filled in. And so the term interstitial lung disease comes from this space that's called the interstitium that's in between two alveoli or air sacs. So now we're on high magnification on the left where you have these normal alveoli. This is where the air would wind up coming all the way down, and it should be nice and thin. And that allows oxygen to get across and carbon dioxide to come out to little tiny blood vessels that run there. But in interstitial lung disease, the idea is that it's anything that affects this interstitium, which is the compartment or space between two different alveoli. So that's just where this term interstitial lung disease came from. And so lots and lots of different things can affect this area, and that's part of why we have so many different causes and types of child. And these are just different examples of how with the pathologists we look and we see different kinds of patterns, and we've gotten better at the terminology that we have, but many of you over the years have heard different terms and given different diagnoses, and that's because we've been working on our terminology. So today in this talk, I was charged with talking about opportunities for research in child. And I wanted to first provide a framework about the types of research. Historically, we used to talk about research as either clinical, meaning that you interact directly with a patient, that's what clinical research means, or laboratory or basic or bench research, which sort of meant people that sat in a laboratory without a patient. And then they started using this term translational for the idea that there were things that had to go in between. But in reality, these lines have become very blurred, and this terminology I don't find so useful. I do all of this, and I think in rare diseases in particular, it's all part of one continuum and spectrum and works best when all of these parts are connected. But when you hear terminology about this is a clinical research project or basic, that's sort of the terminology that what people are thinking around that. So there are actually many different types of research going on in childhood interstitial lung disease. So when we talk about clinical descriptions, this is us saying what are the features of the disorder. So, I try to tell patients, they'll say, I don't know if this is relevant, but I wanted to tell you we have this problem also, or we have this family member who had this. And I say, please tell me, because these are how we make these connections. It might be a clue. Until we know the cause, we don't know if it's a clue or not. But some of these added pieces are often very important clues. Physiology are things like PFTs. Natural history means what happens over time with this disorder. Imaging is usually CT scans right now for most types of ILD, and then pathology is lung biopsies. We talk about pathogenesis, and that means what's the cause. And so a lot of this work is work around genetics, and also genetics and interaction between the environment and genetics. And then it's also cell biology, so what makes cells sick, what happens when those cells are sick, how do those cells interact with other cells to eventually cause a problem. And then preclinical studies is a term for saying, okay, you think you know where you're headed. What are the steps before you give a drug to a patient? And so those are testing things in cell culture in a laboratory or sometimes in animal models. And I'm going to try to give you some examples of these different things related to child here in a minute. And the framework I'm going to use from that is you've already heard about this ATS clinical practice guideline that has been the work of very many people over a long period of time. Jeff Curlin talked about the clinical recommendations from it with the synthesis of genetic discoveries, improved diagnosis, implementing standard terminology. But what I'm going to talk about are some of the things that were in this guideline about what the areas of future research would be. And so this is sort of the roadmap of research that our network set out as this was written about what we saw as some of the priorities for future investigation in child. And there was some discussion about this with the Family Network a number of years ago as this was in development, but I just want to also open it up to say if there are things as I go through that aren't on the list, then I think this is important to also feed back through the foundation in developing research priorities for the foundation and for us. This is how we move forward with things that are important to you and your children. So the areas that were highlighted here are epidemiology, natural history, mechanisms of disease, diagnostic approaches, and therapies. And I'm going to talk through a little of these. So as I wrote them out, I took a little liberty to abbreviate some, but I'm going to give you checks in a minute for things that are in progress or that were talked about yesterday. So I kind of updated this last night as we had our working group meeting yesterday and said, all right, this is what we said we thought were the priorities. Where are we? So the guidelines said we need patient registries. Okay, and then we also need population-based studies, and those are two different things. So patient registries are the patients you've already found, okay, so they're a biased ascertainment. And the population-based is how can you go out there and figure out who you're missing and what else is out there. So we talked about both of those yesterday, and there's been some data presented today related to both. And I'll tell you a little bit about what's been published and where we're going with this. So there are two true population-based studies, or close to that, related to childhood ILD. One was from Ireland and the UK in 2002, where they said there were 3.6 cases per million. And then the other more recently from Germany, a little over 1 per million. Now, remember that this assessment is based on what people call child or ILD, and that this has changed over time as to what counts in ILD, and different countries have different definitions. It's also based on whether it's recognized. So while these are the numbers that they give, this doesn't mean that there aren't cases that they're missing. This is just what they knew they had. So where we start getting into more detailed data is when we find genes, because then there can actually be screening of large population to figure out how often those genes are present. So we have better information about frequency in the population for forms of child where we found genes than we do for causes where we haven't. So this is one study recently led by the group in St. Louis, where they studied a Missouri population-based cohort, and so they had over 1,000 infants. And so an ABCA3 carrier, so one copy of that gene mutation, was found in 3.6% of infants of European descent and 1.5% of those of African American descent. So we know that SPB mutations are extremely rare. SPC mutations are quite rare. We've done that, not me, but that's been done through population-based studies. But what this study was the first to show is that actually having one ABCA3 mutation is quite common. It's actually about as common as cystic fibrosis based on these numbers. And this has been replicated in one data set and will be looked at further. But so it makes us think that we're missing a lot of cases out there related to ABCA3, or maybe there's even milder phenotypes, meaning milder patients that aren't getting recognized. So that's a little bit about population frequency. So other ways in which we try to figure out how much is out there get done in a few different ways. So a European Respiratory Society task force did a survey of their respirologists or lung physicians a number of years ago, and they found 185 cases in immunocompetent children. So I don't know what we don't know what the denominator is. I'm just saying they collected 185 that didn't have immune system problems. In North America, from 11 centers, 10 in the US and 1 in Canada, we collected 187 lung biopsy cases done in children less than 2 years of age. So again, that doesn't tell you anything to tell your neighbor or anyone about how common this is, but these are collections of cases. And then recently, through a network that's been funded in France called the Respirer Centers, they picked up another 205 cases. So I guess what I'm saying is, outside of the little population data that we have for some of the surfactant genetic disorders that have been found, for most of these other forms of child, we don't know. We can start to tell you how many cases we've collected, but that's not the same as saying how many are out there. And that's where dissemination of knowledge and patient registries and other population-based studies will be needed, and those were things all discussed yesterday. So one of the questions I had, having recently moved to Vanderbilt, was to sort of think about, well, how common are these things? I've had the privilege of seeing patients who travel a lot of distance, and so there's sort of a referral bias. And I wonder, well, how many are out there without them being referred to me specifically? And so Jennifer Soares, one of the fellows at Vanderbilt, did a research project with me where we specifically said, let's try to find what we can at Vanderbilt before we formed an ILD center there, where it was just a general pulmonary practice. And we found 93 child cases overall, and we found 8 cases of NEHI. And this included 5 that weren't previously recognized or diagnosed. So because I had taught her about NEHI as she went through CT scans and lung biopsies, she said, aha, okay, so this is a fellow who had seen one NEHI patient ever, and this is really important as you're at different institutions and you're meeting residents and fellows, and sometimes that's hard, but you can have this much impact. If they've seen one case, the next one that comes along, they're much more likely to recognize it. So she found 5 more on her own. There are probably others that we don't know about that never had a CT scan or went through more workup. But the point of this is that it was quite valuable for us in looking at more forms of ILD. We found a number of new cases further since that time. We have many more cases than that, but these are just ones that we found at Vanderbilt before that time. And it kind of suggests to me that these disorders might not be so rare. I mean, they're relatively rare, but they might not be quite so rare, because if there are 179 children's hospitals that report to the U.S. News and World Report survey, and we know some of them are really big and some of them are smaller, but if you just took, what if there were 5 or 10 cases at most of these programs that they didn't know about, and start doing the math of that? We shouldn't just have a few hundred NEHI patients. We should probably head our way into the few thousand, and that would really change a lot about how fast we could make progress in this disorder. And so we're advocating for trying to extend our network and get broad participation from children's hospitals. We have to be practical and feasible about how this goes, but hope that we can set up referral centers and sort of what Robin has called a spoke and wheel approach to get more regional centers to refer into centers of excellence to capture all of these cases and learn from them. Okay, so that's a little bit about how much is out there and how we try to find more that's out there. Natural history. The guidelines said use patient registries to study the natural history, do studies to understand the physiologic spectrum of the entities. That means like how do kids breathe and why and how does it manifest. And then do kindred-based studies, that's basically family studies, to try to understand the association of the pediatric forms with some of the adult lung diseases. And these are all things that were a huge part of the focus yesterday and as we're planning grant applications. Diagnostic techniques was another area of big research focus, and I think this is one where we've probably made the most progress in the 9 years that I've been involved with this network. So the guidelines said we need to work on standardizing infant PFTs, CTBL, and lung biopsy, and there's a lot of good information about this in the clinical practice guideline. There's still more progress to be made, but we're doing a lot better with this. Talked about evaluation of potential biomarkers. That's something that the foundation is helping fund right now. And then when we talk about correlations, what we're trying to understand is how does a CT pattern match up with the lung biopsy pattern, or how does someone's symptoms correlate with what their CT scan shows? And some of you may know that it doesn't always seem to correlate. And at the end of the day, how the kid is doing, I think, is the most important parameter. But if we could understand when those tools help us and when they're predictive, that's what this area of research is about. So those things are all in the works. One area that wasn't discussed at all yesterday, and again, in full disclosure, as I went through all the areas, what were listed in the guideline is social and behavioral studies. So we, in the guideline, said that we think it's important to do studies of quality of life and how these disorders affect families. And there have been a few pilot type discussions over the years, but there hasn't been a real organized approach to this area as yet. One of the other areas that was written in the guideline was evaluation of the economic costs of the evaluation and treatment of these disorders. And Dr. Deering and I talked about this last night, but we didn't talk about it in the research network, so I didn't give it a checkbox. But I think it's important. It's important because part of how we try to advocate for research priorities overall in a time of limited resources from our government is to try to make the case for impact, okay? And impact is, to each of you individually, how your kid is. Impact to the healthcare system as a whole requires us to also produce some data about how, if you invest in this, what's the return on investment in other kinds of ways. And from the patients that I see in the stories, you tell me, I have no doubt that once we kind of get to the right diagnosis and the right test, then we save a lot of money on not going through tests that weren't informative and aren't informative. And many kids once diagnosed are not put in the hospital again, or very rarely hospitalized, because together we sort of sort out what do we expect from this kid and how to manage these symptoms. So I have this opinion, without any fact at the moment, that this can make the case for why pay attention to a rare disease, why is it so important to diagnose these things. But I think together we need to think about how to do these studies, and we didn't really hit that formally yesterday, so we'll need to keep at that. So the biggest category and sort of the meat of things falls into what are called mechanisms of disease. So this is the translation of this is what causes this, okay? And there are a lot of different areas that have to do with genetics and genetic and environmental modifiers, cellular injury and how the lung heals, identifying causes with some of the newer disorders, using animal models and tissue culture models and different technologies. So I don't want to get too deep into all of these, but just to say that there was some pretty intense discussion around the science around some of these yesterday. The ones where there wasn't as much discussion, they're actually things that I work on personally, and there's a lot of research in the lung biology community in general. There was a lot of discussion on these other open areas at last year's conference in San Diego. And I wanted to pause here for a minute because I think it's really important to know that people are studying disorders and studying things that have potential big impact for a child who aren't necessarily seeing your kids. And part of our job as a research network is to be aware of what else is out there and to figure out how to connect the dots and bring those resources to bear when someone might think they're studying something to understand, this, but actually it turns out that there's also a cross intersection with one of our child diseases. So these are not ones, I would not be disheartened at all, because actually there's a tremendous amount of research going on in these areas. It's just not something that was represented at this conference so much this year because of the sort of clinical focus. So I'm going to show you just a few examples of the kinds of work that get done in these different categories related to child disorders. So NEHI, when it was published, part of why it was so puzzling is that the lung biopsies looked normal. So this is that bronchiole or small twig airway that I was talking about. And unless you know to do this Bombesin stain, which marks neuroendocrine cells, you can't really see these cells. They're supposed to be there. We all have some. But in NEHI, Dr. Langston, Dr. Dieterding, Dr. Fan found that kids with NEHI had a few too many. But until they knew to do the stain, the lung biopsies just looked pretty normal. And so the original publication that they said lung biopsies in NEHI are normal, except you have too many neuroendocrine cells. And this caused some confusion because over time, as we started to see more cases, they weren't all quite perfect. Life just isn't really that kind. And sometimes kids had RSV before they got their lung biopsy, and so there was a little inflammation. Or sometimes they had been aspirating a little bit because they were having trouble with feeding coordination while they were breathing so fast. And so then the pathologist said, well, but they said the lung biopsies are supposed to be normal, so this can't be NEHI. And I have a number of patients who were told by pathologists, this is not NEHI, you have bronchiolitis obliterans, or you have chronic bronchiolitis, or sort of other names that were put on it. And so we did a study to try to understand a little bit more about neuroendocrine cells and define the histopathology a little bit. And in this study, Gail Deutsch, who's a pathologist now in Seattle, who's done a lot of research in this field and work with our child network, actually counted every neuroendocrine cell in every slide of the lung biopsy for these cases. And she didn't just count them, she then did a computerized method and said, well, I just want to make sure I didn't miss it, so I'm gonna have a computer algorithm where we draw and measure the area of these. And the two methods were quite reliable, but she's, thankfully for research, quite obsessive. And so what came out of this is that the red patients are NEHI, so there were increased neuroendocrine cells, but it was only in certain locations. It was in the very smallest ends of the airways. It wasn't neuroendocrine cells everywhere. It was in a specific location. And then we kind of said, well, what about this issue of injury? What do we do with that? Because at the point in time, there was a lot of argument about whether you could have NEHI if you had a little bit of lymphocytic bronchiolitis or follicular bronchiolitis, some of the terms some of you may have heard. And so we looked in NEHI, and the black bar here said that actually 10% of the airways that she scored, she went through and gave every airway a score, okay? 10% of the airways had some injury. So not a lot, but definitely some. And these were cases that all had a CT scan showing NEHI such that now many of us wouldn't even do a biopsy because that's how clean the CT scan was. That was the entry criteria to get in. And so, so clearly, some injury in the airways is often seen in kids with NEHI. It doesn't mean we understand it, but it means it's okay. You can still get diagnosed with NEHI even if there's a little bit of injury. And the other thing that I don't fully understand, but here, the neuroendocrine cells, that's what the NEC area is, neuroendocrine cell. The non-injured airways, the gray ones, that's where all the neuroendocrine cells are. The airways that were a little bit injured, they weren't the ones that had increased numbers of neuroendocrine cells. And this is really important because injury to the lungs can lead to increased numbers of neuroendocrine cells. In experiments where they put things like acid into the lungs of lab rats, they get increased neuroendocrine cells. So a lot of people had said, oh, well, it's just because of injury, it's just because of virus. And what we think these studies show are that many kids with NEHI will have a little bit of injury, but it's not, that's not where the neuroendocrine cells are, and it's just part of the spectrum of NEHI. The other thing that she did was some fancy staining to try to look at whether neuroendocrine cells were still proliferating or growing. And the short answer of that is we don't see that. So the green is bombesin, or the neuroendocrine cells, and the sort of pink or red is a marker of cells that are proliferating or growing. And there are cells nearby that are proliferating, but the neuroendocrine cells themselves are not. And this is important because neuroendocrine cells are associated with a range of conditions, and none of us know what they're gonna do over time. Okay, so I want to acknowledge the support of the Child Foundation and the Child UK Lung Foundation. I'm very grateful for support to start to think, to do some work around genetic discovery in NEHI. And I'm not the only physician or investigator around the country, around the world that's looking at this. There are a growing number of families in which there is suspicion of more than, or proven evidence of more than one child who is affected. There are also many, many families in which there's not more than one child who's affected. But it's become clear that there may be a heritable component of this. And so through this support, through the American Thoracic Society, I'm able to do a little bit of work. And I want to just share with you one new piece of information related to this. So this is a NEHI case that presented with what we consider the typical presentation of NEHI, with fast breathing and trouble growing in the first few months of life, and a CT scan and lung biopsy that clearly showed NEHI. In this family, there was an extensive history and an autosomal dominant pattern of individuals that also had failure to thrive in infancy and unexplained chronic respiratory symptoms that had improved with age. And Larry Nogi found that in this patient with NEHI, there was a mutation in a gene called TTF1, or NKX2.1, and that tracked in this family with the unexplained lung disease. So these findings suggest that in this one case, TTF1 mutation is a cause of NEHI. And this puzzled us a little bit because at the same time he just found that TTF1 mutations were a cause of other types of lung problems, ones that looked more like lung surfactant, that they'll talk about in a little bit, and also problems with lung growth and development. And so this was sort of a different way in which TTF1 could affect the lung. Now, TTF1 stands for thyroid transcription factor 1. It's a master regulator of lots and lots of genes that are involved in development of the thyroid and of the lung. And some of the individuals that have abnormalities in this gene, this is not NEHI, just in the population in general, some have thyroid problems, some have lung problems, or different combinations of, not necessarily both. So this is a first report of any genetic cause related to NEHI, but I really want to emphasize that we, in Dr. Nogi's study, did not find these mutations in 8 other subjects with NEHI, and I'm aware of at least 5 or 6 others that have been tested and have not found it. So what does this mean? So we think that this is not the predominant cause of NEHI. It may be a cause, but more importantly, we think it gives us a really helpful roadmap to how to approach and interpret other data and other research that's ongoing. So the studies that are funded through this grant are to do whole exome sequencing, and with that we're going to find all kinds of gene variations because we all have lots of them. And so now that we know that we need to be looking at things that are connected to TTF1 that are downstream of this, we think it'll help us with interpreting that data quite a bit. So you may hear, yes, there has been a genetic discovery related to one patient with NEHI, but we don't have any evidence or recommendations to say that that's going to be the cause and everyone should get tested for this. In fact, it's unlikely to be the case. In individuals that have a history of hypothyroidism or have a family history, then we could have some discussion about that. I think the most important thing is to assess for the hypothyroidism. So if anyone has hypothyroidism, that's something that can be treated. Most of the kids with NEHI had their thyroid function tested anyway because they weren't growing well, and so it led to thyroid evaluation as part of that workup. But because having a TTF1 mutation doesn't allow us to treat the lung disease any differently, we're not recommending this for widespread clinical testing. Be happy to take questions on that. I'm going to switch gears and talk a little bit about some of the other molecular studies, though. So that's genetic discovery is one realm. But other types of studies are animal models, These are usually mouse models, and there are mouse models related to many of the surfactant genes and many others that are talked about. And then there are cell culture systems, so ways to use cell lines or even cells derived from patients to try to understand what's going wrong and how to treat it. So for those of you who haven't, for many who haven't heard discussion about research in mice, I just wanted to include one slide about why we do research in mice. It was not something I planned to do when I was in medical school or even in residency, but when I sat with patients in the clinic and didn't have answers, I got a much more open mind to thinking about approaches to discovery. And so the reasons why a lot of biomedical research is done using mouse models is because it allows us to start at the beginning, before there are environmental exposures and all kinds of other complicating features. We control the environment and the exposures, so we can kind of study cause and effect in a controlled circumstance. It's much easier to get lung cells to study from mice than from patients, especially repeatedly. And then we can genetically correct their cells, so we can do what are called sort of proof of principle experiments to understand what happens if you alter this gene or have too much function related to this gene. We can do that in a mouse. And importantly, we can test ideas first there to decide whether there's scientific merit and what makes sense to then try in people. So I want to show you one example of some recent research from some of my colleagues related to this area. So the idea with a mouse is that you can introduce genetic mutations, you can expose them to different things, and then actually it starts to look like looking at lung biopsies from your children and the other kinds of things. We look at lung pathology, we look at cells, we can actually do a pulmonary function test of sorts to measure lung function in mice. So a lot of the endpoints we see are similar. So I won't go into details about the genetics of this mouse, but this is a model in which there's a mutation in the surfactant protein C gene, one of the causes of CHILD, and there's one particular mutation. And what my colleagues John Krofsky and Tim Blackwell have found that when they expose these mice to a common virus, a herpes virus, the mice that have the surfactant protein C mutation get lots more inflammation. In the gray bars, those are different types of cells on the BAL of a mouse, the bronchoscopy equivalent in a mouse. And then they don't clear the virus. Over on the right, the virus just lingers and continues replicating. And so why is this important? Well, in patients, adult patients with different forms of pulmonary fibrosis, they found high levels of herpes virus lingering in the bronchoalveolar lavage fluid or in lung tissue. This hasn't been looked at in kids, but in adults with ILD, they kind of were saying, having trouble clearing virus. They said, well, let's see what happens when we use our mouse model to introduce the virus and see what happens. And the answer is that it causes too much inflammation and it lingers. And then more than that happens. When they let this go over time, the mice actually get fibrosis. So on the left-hand panels are lung sections taken from mice that have this mutation in the surfactant protein C gene. So that's an SPC model. They've been exposed to virus, and after 3 and then over time, their lungs are scarring, and we can measure the amount of collagen or scar in the lung is what the graphs are on the right. So what does this tell us? This is trying to teach us about how we can use this model to understand the mechanisms by which virus might be driving interstitial lung disease and scarring, and thinking about how to intervene and prevent that. The other type of laboratory or bench type research that is getting done related to CHILD, that's just one animal model. There are many, but just one example. The others are getting done in different cell culture systems, and this is a way to potentially more quickly evaluate potential therapies that are then worthwhile to move forward. So this was a paper published last year from the group in Cincinnati in Tim Weaver's lab, using a drug that is clinically available. It's called 4-PBA. Looking at surfactant protein C. So just by brief background, there are a lot of different SPC mutations. Okay, so we've got all these different forms of CHILD, right? One of the types of categories of CHILD is surfactant disorders, and within surfactant disorders, we have different genes, and even within the SPC gene, we have different mutations. Okay, and the point of this paper is that which mutation is really, really important. So there's I73T, which is the most common mutation in SPC, counts for about 1/3 of cases. But then there are other mutations. One's called delta exon 4 that affects part of the gene. And then there's this other one, this L188Q, which is the one that was found in a cohort from Vanderbilt a long time ago. And that's part of why they have the mouse model. So they found the gene in people and said, what's this doing? And so they went and made the genetic mouse to be able to study it. But so there are different types of SPC mutations. And in this study, what they did is they took cell lines and they introduced these different surfactant protein C mutations in cell lines. So they tried to have a cell system representing the different types of SPC mutations in different patients. And then they treated the cells with this drug, 4-PBA, and looked at, did it help SPC go where it needs to go and get made in the way it's supposed to be made? And what they found is that it worked for one type of mutation. It restored the trafficking of the abnormal SPC when there was this L188Q mutation. That fixed it back to normal. But it didn't do anything to help trafficking of other SPC mutations. Okay? So what does this tell us? It says, well, these are cells. These are not even mice where lots of cells interact, let alone a human. And so further studies are needed, but it makes us think that maybe this could be one of other potential treatment options for patients with some specific SPC mutations. But not all SPC mutations. All SPC patients aren't the same. We're going to have to individualize therapy by understanding what goes wrong with those individual mutations. So we really have to have a very detailed understanding of the mutation specific, what its function is, and test it through these different systems if we want to have informed ideas about which therapies make sense to try in patients. And so we start with many, many forms of child, and I show you this to say that within rare diseases, things are still complex, and we can't lump and necessarily treat every child the same. So to summarize the areas of what I see a recent progress are this clinical practice guideline. This is a big part of our efforts to disseminate knowledge. And improve clinical phenotyping just means we think we're getting better at describing what we see and understanding that there are different flavors of knee-high, there are different subtypes of the different forms of these disorders. The registry development is a really important step for many of these things, as I've tried to highlight. The genetic discovery you'll hear more about as well. And then there's a lot of lung disease science in cell systems and animal models that we think provides potential for targeted therapies. But in this type of areas, there are some hits and some misses, and it's our job as a research network and through this conference to try to find the intersections of that lung biology to bring to bear on these disorders. So as I went through the checklist and to sort of keep us all on tack about what we need to move forward, there are many opportunities. We need to find more cases. You all help do that as you educate your doctors locally. They see you. Once we've had a physician involved in this network or a fellow who's trained at one of our centers and they go somewhere else, they'll immediately find another case. So that means that familiarity makes a big difference. And the learning curve is pretty steep. We're working on registry refinement, and this needs to be prospectively implemented. Genetic discovery, understanding the cell biology of what actually goes wrong. So you can have a genetic abnormality, but not understand how that makes a cell sick, and how to correct the problem. Because ultimately our goal is to identify therapeutic targets and get to trials to treat these disorders and prevent them. So I got started in this area when I was a fellow in Cincinnati. Because of a grant to study a number of different rare lung diseases. And Bruce Trapnell, Frank McCormick were studying adult lung diseases, and they had the foresight to say, you know what, let's look at hereditary interstitial lung diseases, and invited Robin Dieterding to organize a conference and start to organize this field. And so the way they looked at this is that you had to start with describing a disorder. You got something rare, what do you do? You have to describe it. You have to figure out the pathogenesis, that's what causes it. Okay, then from there, when you figure out what's going wrong, then you have an idea of where to shoot for what you need to fix and correct. And then you do what are called these preclinical studies, and that's a little bit of what I tried to show you in cell systems or in mice to intervene before you then do what's called a pilot study, which is a study with a small number of patients trying to make sure that things are safe. And then you do a big trial to ultimately get to a therapy or cure and ultimately prevention. And part of what they recognized is that you have to have an engaged patient community to do that. So we're here studying these rare disorders because of you and because of your kids that we see in the clinic that drive us to move forward with this. And I study a number of different rare diseases, but this is part of why these diseases and why now. And so I just want to thank you for your partnership and emphasize that you help in so many different ways. So one is funding pilot studies, but others that are quite important are the ways in which you advocate for research, not just for CHILD, but for your neighbors and community understanding the role of biomedical research in the health of the population in general. It's a lot easier for you to advocate for research than for me. It's your kids, and people respond to that a lot better than me doing my job. So in doing so, I also want to emphasize that you can influence your centers to partner with you to improve care of your kids and to encourage research. Many of the docs that come to this conference come because they have a patient, they interact with the network, that grows our centers, and that helps other kids in that region as well. Your participation in research is how this moves forward. It's always optional, but it has a huge impact. As you support other families, you kind of fuel the system in that way. And then I just want to thank you for the inspiration, motivation, and direction that you and your children provide. So while some of this may sound like kind of science that feels a little bit disconnected, for me and for all the doctors that are here, it's not, and it needs to move forward urgently for your children. So I've been fortunate to work with many collaborators through the network and folks in my lab and others, but I'll just stop here and be happy to take any questions.
Who's first?
The one study you spoke of where the patients were harboring more of the virus, do you think there's we are fighting Epstein-Barr virus at my house, and which I know is different than strep infection. It's making me crazy. But I keep asking my doctor, like, isn't this just a little odd that, we have this and now we're dealing with these other really weird things that no one had seen before? Do you see any connection with your other patients of having prevalence or predisposition for other weird stuff like that?
Yeah, it's a good question. So it depends on the form of child a little bit. I try to say there's so much we don't understand that I give the benefit of the doubt that things might be related until I can prove otherwise. I have to say it could be. With some of the forms of child, there is some effect on immune function. If you ask pulmonologists in general, we struggle with, if kids have chronic lung disease, then they don't tolerate their viruses as well, and so we're more aware of them, whereas we know kids in general get these things frequently, and more of them just fly under the radar. So they'll say, are you sure they're really getting things more often versus just being aware of it more often? There are some of the forms of child can affect how virus is cleared, though, and that's one of the things that's very interesting related to these mutations. It's only some of the types of mutations and how they affect the cells. There's been work done with RSV related to surfactant protein C mutations. That's a bad combination as well. So, this is part of why we, try to advocate strongly for your kids around these aspects of prevention. So I would say there's probably, without knowing all the specifics, it's something that would still catch my eye to say, is this taking a typical course? And if it's not, then maybe there could be some relationship.
I know that there's probably a lot of families in here who are knee-high families who maybe have another child, or they would like to have more kids, and they think, is this going to happen again? I am a multiple child-affected family, and this is kind of different for me because there are two different types in the child form. And I'm pretty sure, from what I know, we're probably the only family that's in the known category that has two children affected with two different child types. So both we're told are not genetic. So what would your suggestion be for steps further? Because Dr. Nogi has all of our stuff. I think you may have some of it for what you've been doing on the genetic side. But what are the odds of that, and what do you do with that information? I know it's kind of a out there kind of a question because it's just so many variables there.
Mm-hmm.
But I mean,
So we should probably talk a little more offline.
yeah.
But let me give a little bit of experience from the adult ILD world to partially answer that. So there's a disorder called familial ILD, or familial pulmonary fibrosis. And so in families, it's been well described that there are different forms of interstitial lung disease in adults in the same family. So it can take on a different face, if you will, or a different pattern within families for lots of types of lung disease. The lung has sort of a repertoire for how it handles injury or insults, and you could wind up over here responding in this way or in this way. So there's plenty of precedent for that in pulmonary or lung medicine in general. It is possible that they are different disorders caused by different causes. It's possible that they have the same susceptibility, and then other things came along to cause them to take slightly different, to present themselves in slightly different ways and different flavors. Either of those could be possible, but why don't we talk a little bit more offline?
So I have a quick question about,
please.
since there seems to be such a disposition to think that a lot of these diseases are caused by genetics, I think a lot of our kids have had genetic workup done. I know both of mine have, but my geneticist and my pulmonologist are not necessarily talking, and I think that may be the case. How do we help science come along and say, hey, geneticist, talk to the pulmonologist, and maybe somebody can find a commonality there?
So it's a great question, and probably a great question for the next speakers as well, who do much more genetic research than I do. So this is a continually evolving field as to the technology for the way that testing is being done, the genes that are known, the interpretation of the data is moving very, very fast. I can tell you that when I send patients to the geneticist at our institution, whether for a lymphatic disorder, an unknown child disorder, for anything, I have a conversation because I want them to have an opportunity to think about it before you get there. I don't know. I'd like to have an opportunity to think about your child too before I see them in consult, and that's why we ask for records and want to be in touch with your referring physician, because I think it goes better. Some people are really, really quick on their feet maybe, but so, I think that your role and what you can do to facilitate those interactions too is to try to help with that, to ask those questions about care coordination. And if you're going to a new center for the first time, make sure that your records are there ahead of time. Get your referring physician or someone else who has seen your child, say, can you just write a one-page summary, or even a half-page email kind of hitting the high points and what our questions are. If you have key questions that going into that consultation, forwarding them to having the secretary give them to the physician or the program coordinator working at that center, I always say that's great. I love to have some of the questions ahead of time. Not that it has to be an exhaustive list, but it helps me know and orient my thoughts coming in of what I'm looking for to know what you're going to be asking. So there are some places that are moving to having the geneticist and the pulmonologist see the patients together. I've worked in some of these models where you can run through 10 physicians and it's dark by the time you leave. Different centers have different models for how to do this, and I think different approaches work in different places. So the lines are getting a little blurred around what gets done as a clinical test and when things need to move over to a research realm. And as a network as a whole, we're having these discussions about what's clinically indicated testing that should be ordered by doctors and insurance should be requested to pay for, versus when things are not affecting clinical management and are really in discovery and get done on a research basis. So if, as a long answer to your question, it's an area that we're aware of that's hard, and I would just encourage you in general to to whenever you have a referral to anybody else, whether it's to a GI physician or endocrine or anyone else, you just don't want to show up as a surprise.
Just a quick question for
Yeah.
you. Because so many of our kids have had genetic testing, are you collecting information on kids who have tested positive for something in like the microarray, or are you guys taking that information and are you doing anything with it?
So I'll let Dr. Dieterding in the wrap-up talk a little bit about where we're going, a little bit more about where we're going with this, but just to give you the current state of these things. So right now, the registry that's in development, as cases are entered, there is opportunity to enter what clinical genetic testing has been done, what's been ordered to those labs, and that would include microarray studies, any genetic testing that's been done. Data that has been generated on research protocols at different institutions is not part of your clinical medical record. That's part of research studies, and so that wouldn't be in your clinical record. And so these are part of our research protocols that we need to organize as a network going forward for how that type of information gets synthesized. So even though it seems very obvious, these data exist in different spheres right now. So right now there's not a single repository of a network of everything that was done, ordered by a doctor as a clinical test, and everything that was done by anyone, anywhere in research, that's merged right now. But that is one of the challenges. So I'll just, before I wrap up and hand it over to others, this is one of the things where I'll make a request or plea. As these studies are expensive, we collaborate and work together with other investigators and as a network. And so when your children are enrolled in other research studies that are aimed at genetic discovery and are using some of these new technologies, we would be quite appreciative of your sharing that information with us so that we don't do the same test and spend foundation dollars that are being used for pilot studies unnecessarily if that type of study is already being done under another research protocol. We can't call up and say, do you have a sample for patient name this, unless you're our patient. We don't have that information, but you can share that with us and allow us to use the resources that you all work so hard for more responsibly and efficiently. So, thank you.